Professor Dr. Pradeep Kumar, Brolucizumab in Neovascular AMD, the Indian experience.
Morning to everyone. So this research is a little bit old now. It has been published earlier, about 6 months back. And so I'll start with the Indian experience of Brolucizumab in treatment-naive neovascular AMD. Dr. Chakrabarty's work was published earlier than us, and it talked about the injection in all kind of neovascular AMD. But we were choosing neovascular AMD eyes which were treatment-naive here. And why we decided to compare Brolucizumab in India, one, there were racial differences compared to the Hawk and Harrier study results. There was an environment impact. And also we wanted to find out whether the supply chains were authentic till the last modem. And we wanted to remove any commercial interest, us being a government organization where the cost of treatment does not make any impact on the patient or the doctor's choice. So this was our research which was published. And why we wanted to compare it with aflibercept was because aflibercept was conventionally well accepted molecule and was believed to have a stronger anti-VEGF effect compared to ranibizumab, which was the conventional molecule as of 2020. It was believed to be longer lasting. FDA approval was already available for 8 weeks. And we wanted again to find out if we remove the price tag, which particular drug will be chosen by the doctor. So the unanswered questions were whether Brolucizumab gave better visual recovery compared to the conventional molecules. Was it able to increase the inter-injection interval? What were the adverse events in Indian population? And if those adverse events occurred, were these eyes lost forever? So these were the necessary approvals which were taken. And we went ahead with the same inclusion and exclusion criteria as Hawk and Harrier. Pertinent to mention that patients with vision less than 3/60 were not considered for this particular study because the impact of anti-VEGF in changing the anatomical structure, whether it translates to visual differences, cannot be ascertained at less than 3/60 visual criteria. So we took the necessary approval, the consents, and the randomization was done based on simple randomization envelope calculator system. There were 3 initial loading doses, and after the 3 initial loading doses, the patients were examined at mandatory 4-weekly interval. This is where we deviated from the Hawk and Harrier module. We did not give a necessary 8-weekly or 12-weekly follow-up schedule. The follow-up schedule remained at 4-weekly intervals. And whenever these retreatment criteria were met, the patients were re-injected. The adverse events were graded as 1 and 2, which are common side effects which are seen after any intravitreal procedure. And grade 3 and 4 were the interesting side effects, where grade 3 required topical steroids to be administered, and grade 4 were the serious events where systemic steroids had to be given to manage the patient. We had well age and sex match control groups, 56 patients being in Brolucizumab group and 58 being in aflibercept group. And the baseline visual acuity and the central macular thickness criteria were similar. We were also trying to find out that what were the changes occurring in different compartments of fluid at the macula, that is the IRF, SRF, and the subretinal component. So this is how the BCVA behaved, and as expected, both aflibercept and Brolucizumab caused vision to improve significantly. In Brolucizumab subgroup, it was just a shade better, but not statistically significant. But what was interesting was the change in the central macular thickness. As has been reported by other authors, the drying effect of Brolucizumab is higher. It was 112 micron in this subgroup compared to 86 micron in aflibercept group. And we tried to find out that which was the fluid compartment which was being affected the most. It was the subretinal fluid compartment which was being impacted at 8, 12, 16, 36, 44 and 48 week, the maximal. We also found out that the inter-injection interval after the 8th week dose was much higher in the Brolucizumab subgroup, requiring only 94 injections up to 48 week in the total group compared to 180 aflibercept injections. And the duration was mainly between 12, 16, 20 and 24 week in the Brolucizumab group, while in the aflibercept group we realized that patient behaved between 4 to 12 week interval at the most. Compared to the adverse effects, Brolucizumab group did have significant adverse events, as in scored 3 groups,
Screen.
There were 9 such score 3. Apologies. So let me continue. The score 3 events which were requiring topical steroids were about 9 such events in Brolucizumab group compared to just 2 such events in aflibercept group, and the severe effects where we had to give systemic steroids to patient occurred only in 1 patient in our Brolucizumab group, while in the aflibercept group no such events occurred. So what we gathered out of all this was that Brolucizumab was giving a longer inter-injection interval. It was working just as good as aflibercept as far as visual gains were concerned, and it did cause significant adverse events, but the adverse events were manageable. And if we talk that what are the impact it's going to make on the country as such, one, it is going to reduce the visits of the patient to our clinics, and these lower number of injections are going to translate to better economy when the final pricing points will be concerned. The risk benefit ratio when compared to lesser number of intravitreal procedure in Brolucizumab group will finally translate to almost similar as compared to aflibercept subgroup. Thank you so much.
So thank you. It's the same. You show that the advantage is that it has increased the time interval between the injections.
Yes, ma'am.
But also, having said that, you show that there is a higher risk of adverse events,
Yes, ma'am.
which apparently you don't get in aflibercept.
Yes, ma'am.
Now, is it really worth taking that? Because despite you not getting any vascular occlusions, there's a potential risk of that, and we do consider that that can happen in any patient, though the percentage risk is very low. So, will you give more, weightage to the interval time being reduced between injections, or more weightage to the risk of adverse events?
Ma'am, I'll give more advantage to the inter-injection period increasing. And now, since we are wiser over the period of time, we just concluded our 1000th injection last month. There were just 2 important adverse events in 1000 injections, and all 2 were recoverable. One occurred in our own hospital matron, senior lady. She recovered, and now she is maintaining the same baseline vision where we started from. Similar event occurred in another gentleman. Now, if these adverse events are manageable, these patients who are visiting me now at 3 monthly interval, it is a much better scenario. Our OPDs are leaner, we have lesser post-op visits, and these patients are happier because they don't have to come in so often. So if I translate this to patients who are not treatment naive, we are talking about 2 to 3 Brolucizumab in a year compared to about 4 to 5 aflibercept. Our experience with aflibercept is also for about 6 years now. We know it's a good drug, but it has 4 to 5 injections per year, almost that is what is required. So that's my summation.